Hello guys, welcome to my YouTube channel. Today we are going to talk about the topic organophosphorus poisoning. Let's look at the introduction of organophosphorus poisoning. It is the most common cause of acute poisoning in India. Common organophosphorus compounds are malathion, parathion, dichlorvos, diazinon and chlorothione. These compounds irreversibly inhibit acetylcholinesterase and cause accumulation of acetylcholine at muscarinic and nicotinic synapses. Okay, let's look at this diagram. Organophosphorus compounds can be made into two different types. It can be insecticides, it can be nerve agents. Insecticides causes inhibition of neuropathic target esterases, organophosphate induced delayed polyneuropathy, which is a disability. It can also cause inhibition of acetylcholinesterase, accumulation of acetylcholine at the muscarinic, nicotinic and CNS receptors, which causes acute cholinergic syndrome. It can also cause excess acetylcholine at the neuromuscular junction, which causes downregulation of nicotinic receptors at the neuromuscular junction, which can cause intermediate syndrome. Both of these can lead to death. This diagram shows how acetylcholine binds to the receptors in the postsynaptic neuron. First, let's take acetylcholine signaling at the synapse. Okay, this is the acetylcholine receptor. These black squares are acetylcholine. Okay, when the acetylcholine binds to the receptor, okay, it produces signal. But in case of what is the role of acetylcholinesterase? Acetylcholinesterase, they are the star-like are these stars. Okay, after the acetylcholine, enough acetylcholine binds to the receptors. Okay, the excess acetylcholine which are present in the synaptic area are taken up by acetylcholinesterases, which are then degraded. But in case of organophosphorus poisoning, what happens is, as it inhibits the acetylcholinesterases, you can see that the excess acetylcholine is left behind. Okay, because they cannot be degraded by the acetylcholinesterases, because organophosphorus compounds binds to the acetylcholinesterases. Let's look at the pathway of the neurons in case of sympathetic system and parasympathetic system. In case of sympathetic system, the preganglionic fibers at the end releases acetylcholine, which binds to the nicotinic receptors on the postganglionic fibers, which then finally release noradrenaline. Okay, but in case of parasympathetic system, the preganglionic fibers release acetylcholine, which acts on the nicotinic receptors of postganglionic fibers, and which again release acetylcholine, which binds to the muscarinic receptors. So as you can see that acetylcholine is released in three cases: acetylcholine by the preganglionic fibers in sympathetic system, and acetylcholine in preganglionic fibers in parasympathetic system, and acetylcholine in postganglionic fibers in parasympathetic system. So we can see that the acetylcholine acts on nicotinic receptors and muscarinic receptors. Okay, so basically organophosphorus compounds inhibit the action of these receptors, nicotinic and muscarinic receptors. Let's look at the clinical features of organophosphorus poisoning. First, the muscarinic manifestations. Dumbbells. You guys know dumbbells. What is it? D stands for diarrhea, U stands for urination, M stands for micturition, B stands for bronchuria, E stands for emesis, L stands for lacrimation, and S stands for salivation. Okay. Other muscarinic manifestations include nausea, vomiting, abdominal pain, and fecal incontinence, increased bronchial secretions, cough, and occasionally pulmonary edema, excessive sweating, salivation and lacrimation, blurring of vision and meiosis, increased urinary frequency and incontinence, bradycardia, hypotension, and conduction blocks. Let's look at the nicotinic manifestations. It includes twitching, fasciculations, weakness, diminished respiratory effort, hypertension, and tachycardia. Let's look at the CNS manifestations. These include anxiety, restlessness, tremors, convulsions, confusion, weakness, coma, intermediate syndrome. It includes syndrome of muscular paralysis, which occurs within 24 to 96 hours after ingestion of an organophosphate and following treatment of acute cholinergic syndrome. Muscular weakness affects predominantly neck flexors, proximal limb muscles, those supplied by cranial nerves, and respiratory muscles. Organophosphate-induced delayed polyneuropathy, cramping muscle pain in the lower limbs, distal numbness, and paresthesia, followed by progressive weakness, depression of deep tendon reflexes in the lower limb, and in severe cases in the upper limb. Let's look at the diagnosis of organophosphorus poisoning, which can be confirmed by demonstrating a reduction of cholinesterase activity in plasma or in red blood cells to less than 50% of normal. Management of organophosphorus poisoning: immediately when the patient comes to the emergency after ingesting the organophosphorus poisoning, we have to ask the history from the person who is accompanying the patient, and when we get to know that when we get a clue that the person might have ingested an insecticide or something, we have to do general measures, that is, remove the patient from the site of exposure and wash the skin with soap and water. In case of ingestion, gastric lavage should be done in patients presenting with in the first 1 hour of ingestion. Activated charcoal is given orally at the dose of 1 to 2 grams per kg body weight. Meticulous care of airway along with oxygenation is important. It is if there is respiratory insufficiency, patient should be ventilated. Benzodiazepines can be given for convulsions. Specific measures include atropine. Atropine is the main antidote. If the initial assessment reveals significant cholinergic effects, that is meiosis, excessive sweating, poor air entry due to bronchoria and bronchospasm, bradycardia and hypertension, then atropine is required. Atropine is administered at the dose of 1.8 to 3 milligrams intravenously. 5 minutes after giving atropine, check for the 5 markers of cholinergic poisoning, which I said earlier. A uniform improvement of the 5 markers is required and not the improvement of just one. If after 5 minutes the consistent improvement across the 5 parameters has not occurred, then more atropine is required. Double the dosage of atropine every time and continue to double each time when there is no adequate response. Target endpoints for atropine therapy include clear chest and auscultation with no wheeze, heart rate greater than 80 beats per minute, pupils no longer pinpoint, dry axilla, and systolic blood pressure greater than 90 milligrams of mercury. Pupil size and heart rate alone should not be used as endpoints. Other antidote is pralidoxime. Pralidoxime is a cholinesterase reactivator. It is effective for nicotinic as well as muscarinic features of toxicity. The usual dose is 30 milligrams per kilogram, initially over 20 minutes, followed by constant infusion at 9 milligrams per kilogram per hour. It is usually continued for 12 to 24 hours after atropine is no longer required. Thank you. I hope this video was very useful to you guys. Please like, share and subscribe my YouTube channel. Thank you.